All right. Hi, everyone. Thank you for joining us today for this webinar titled Navigating the Weaknesses, Challenges, and Discovering Opportunities for Advancing Health Equity in a Complex Healthcare Landscape. My name is Bryant Harvin, and I am the founder and chief executive officer of the National Alliance on Ending Health Disparities. And I'll be your moderator for today's conversation today. Before we begin, I just want to take a moment to share a little bit about this organization that's behind today's conversation. So the National Alliance on Ending Health Disparities is a new nonprofit organization with a mission to support and empower individuals, healthcare professionals, and decision makers through research, education, and advocacy initiatives to eliminate health disparities in all communities. So, NAID was born out of lived experience and deep frustration with the current healthcare landscape. My sister, Donna Harvin Graham, who's on this call today, is a lot of the reason NAID exists today. Donna is a rare disease patient, a partner, and an advocate, not only for herself, but for some countless others who face the same barriers, delays, and dismissals while trying to navigate proper care in the system. Her journey exposed many cracks in our healthcare system, um, which pushed me to build something different outside of my own experiences. Something accountable, something collaborative, and something that centers and elevates everyone. What makes NAID unique is our structure. NAID was built as a collaborative approach to ending health disparities, one that unites everyone from patients to healthcare professionals to students to researchers and corporate entities. There's a place for any and everyone in the Alliance. We're proud to be the first organization of its kind to bring together such a diverse range of individuals under one mission to end health disparities through research, education, and advocacy initiatives. Now, with that being said, the Alliance welcomes you all to this presentation today. We're honored to have you here, and we're grateful you've chosen to spend time with us in this space today. All right, first, I would like to start off by recognizing and thanking Ultragenyx Pharmaceutical Inc. for sponsoring this conversation today. At the conclusion of this conversation, participants will be able to achieve the following learning objectives on this slide. And now I'm excited to introduce our panel for today's conversation. We have Dr. Stephen Bezruchka, Associate Teaching Professor, Emeritus Health Systems and Population Health with the University of Washington. And we have Dr. Jamila Meschner, Associate Professor with Cornell University in the Department of Government and Brooks School of Public Policy. We also have Dr. Michelle Herndon, Director of the Patient Navigation with the Undiagnosed Diseases Network Foundation. And finally, we have Sarah Marshall, Program Development Manager at Undiagnosed Diseases Network Foundation. Two things before we dive into today's conversation. I'd like to first share a quick visual from Dr. Bezruchka, which is often referred to as the Health Olympics. This chart, it ranks countries by life expectancy. And as you'll see, the United States falls near the bottom. Despite our high healthcare spending, our outcomes tell a very different story today. All right, let's now get into our conversation. All right, so our opening question directed to the entire panel. What does health equity mean to you, not just professionally, but also personally? Any one of you can just jump in first.
I'm happy to jump in. Hi, everyone. Nice to have you all here. And I know that it's no small thing, depending on what time zone we're in, towards the end of the day for many of you, or maybe the middle of the day for some of you, to take this time out to think about something that's really important, which is health equity. And I think, however, many of us are consistently making that effort to continue these conversations and to extend them to work in our everyday lives and practice, the better. So, as Bryant mentioned, my name is Jamila Mitchner, and I'm a professor at Cornell. Of course, I study health equity, so I could give you a definition that was like more academic, but I appreciate that this question prompted us to think about what health equity meant to us personally. Um, I think when I first started to study health and health equity as a young graduate student, getting my PhD, in my early 20s, perhaps there weren't as many personal connections that I was aware of, right? I'd grown up low income from an immigrant family. And I think as I continued to do research, it became clear to me how much health equity meant for the communities that I lived in, for my own family, for my own loved ones. But also, as I continued my way through my adult life, the kind of connection between what I was studying in the health policy and health equity space and what I was seeing unfold in my life and the lives of people around me became more and more clear, right? So, experiencing really intense and frankly life threatening discrimination personally when I was giving birth to my first son, and just being grateful that I made it out, frankly, alive, given some of the ways that I was treated really struck me. It stood out to me and made me think about something like maternal mortality differently than I had thought about it before. And of course, even though I grew up on programs like Medicaid, and that's part of what motivated me to study it, it wasn't until my mom was in her final years and was unable to manage her own Medicaid case, and I had to manage it for her. And by that time, I had written a whole book on Medicaid. And the things that I learned simply by trying to keep my mother alive and well, make sure she had transport to her appointments, make sure she was cared for and treated her humanely, and the how much against the grain I had to go in order to ensure those things for my mother as a low income Black woman. Again, it created a real bridge between the research and the lived experience for me. And so I've been able to grow more as a scholar and as a person as I've understood this connection. And it really roots and motivates my understanding of health equity, which in the simplest terms to me just means that everybody, no matter their background, no matter the category that we might place them in terms of a racial category, a gender category, an income category, a life background, a neighborhood, and so forth, that those things will be uncorrelated with health outcomes. Those will not be the things that dictate our health, right? And that everyone across those categories within and between them will have the access to resources and services that they need in order to maintain a healthy life. I'll stop there.
Okay, let me go next. Quite simply, health equity means that my health is not compromised by the country in which I live, nor by my skin color, my education, or wealth status.
Um, my name is Sarah Marshall. I am the program development manager at Undiagnosed Diseases Network, but my experience both as a parent and professionally span far beyond the Undiagnosed Diseases Network Foundation. I think of what you said, Dr. Mishner, about maternal mortality, and I worked for 15 years as a birth doula and attended births and saw inequity and like you said, it was irrespective of education level sometimes, irrespective of skin color, of income, that there were inequities, that it didn't matter kind of where you landed. And our maternal mortality rate in this country is I think the worst in the developed world, or close to the worst. And so I mean, I've seen equity versus inequity in the maternal and infant world, I'm also the parent of a mother, or I'm the parent of a child with an undiagnosed disease. And, I work with other parents who have undiagnosed children and people's ability to access care, know how to access care, um, and have the means to do it, whether they're on Medicaid or even particular insurance companies. I see parents fighting literally days on end to get a treatment approved to be paid for by an insurance company. And so and then outside of those things, I'm also a medical case manager for women and children living with HIV, mostly immigrants, poor women, and see barriers to transportation being a huge piece geographically where you live, whether you live in rural parts of the state or a metropolitan area. And so it's really the systems that we've set up that in large part create the barriers. It's also, the learnings that our medical care providers have about their kind of notions about groups of people that impact equity, I think. But I think in large part, it is the systems that we've created that create inequities. And I'm realizing I'm not maybe answering your question, but equity means that we've created a system where anyone and everyone can access the same services to achieve a health status that they want or is acceptable to them. So, very long-winded answer.
Well, everybody's kind of touched on something I was going to say and did it so eloquently. But I mean, I guess I'll just draw a little bit on what Dr. Michener shared and then Sarah's experience as well. I am the director of patient navigation for the Undiagnosed Diseases Network Foundation, but also I'm a parent of a son who passed away from an ultra rare disease when he was 19. And he had a 7-year diagnostic odyssey. So we went for 7 years without knowing what disease he had. And his disease was ultimately discovered by the Undiagnosed Diseases Network, which is an NIH-funded research program. And during that 7 years, I found myself, frankly, someone with almost as much privilege as you could imagine in the United States, college educated, urban, worked at an academic medical institution, had amazing health care, and I was still finding myself crying on the phone with insurance companies, fighting with receptionists at doctors' offices, trying to get appointments for my son with specialists who had months and months of a wait while they're telling me, no, make an appointment for next week. And I, fighting with that receptionist. Everybody knows about that scheduler in the office that you're just fighting with, and thinking, I can do this. I have experience in, communicating, and like I said, college educated. I can do this, but found myself like losing it with, this medical system I was involved in, and just started thinking, what about the mom who doesn't speak English? What about the mom who lives in rural, Midwest and can't take off a day of work to drive 4 hours to the big city for the specialist? And so, what health equity means to me is, even though I did, experience some barriers with my son's undiagnosed journey, and I want to get those barriers resolved, they were nothing compared to what so many millions of Americans experience. And I want to make sure that I can do my part to make it better.
Yeah, thank you all so much for sharing those thoughtful answers. We definitely have our work cut out for us, which sort of leads me to our next question. In your opinion, what does true collaboration looks like when advocating for health equity across diverse stakeholders?
I'll take a stab at that one. I think true collaboration includes the patient voice. Patients have to be involved in directing their care. They have to be involved in the systems that create the care. And without patient voices, it's just not going to be as good of a system. And so that's what I mean, collaboration and right now, systems are siloed. Specialists don't talk to each other. No one really talks to each other. It's like, oh, well, go see the GI doctor. Well, no, this is not a GI problem. This is an endocrine problem. Go see the endocrine, but there's not talking in between. So collaboration means that doctors have the ability and time to collaborate with each other, but also kind of be inclusive of the patient voice in not only the direct care, but also the system in which it's built.
I think the collaboration we need is to recognize that we die younger than people in all the other rich countries and quite a few less rich ones, as Brian pointed out in the Health Olympics slide. And we spend half of the world's healthcare bill to achieve this. So you have to conclude that the impact of healthcare, at least spending, does not really reflect the health outcomes that we have at the end. So once we admit we're dead first, then we need to work together to try and do something to change that, because there's a general belief that America is the best at everything, but certainly not when it comes to health.
I'll chime in here and say that I think along the lines of what other folks have said, although I'll put a fine point on, a key element of what I think is sometimes overlooked and sometimes missing is a recognition that the current status quo with respect to health equity, the way that things are, right? And whether those things are in relation to the health benefits and outcomes that we have in relative to the amount that we spend, in relation to the kind of for-profit system that structures all of that, and so forth. Those things are determined by who has power, the distribution of power and influence in our society. And the people that are most affected by health inequity are not the people that have power, right? The people the immigrant women that Sarah Marshall talked about, the people with undiagnosed illnesses who have to navigate a system that's for-profit mechanisms don't lend itself to the appropriate treatment of rare diseases and conditions. The low-income people, the racially and economically marginalized people, those are not the people who have power. They're not the people who are structuring our policies and our politics that shape our policies. And it's that power imbalance that allows all of these different elements to remain as they are. And so when I think about what kind of collaborative work needs to be done to see change happen, I think Sarah said something about the patient being the center. And I think that's right. And I'd go even beyond that and say the people whose lives and communities are most affected, they may be patients, they may not. They may be family members of patients. They may be sons or daughters, or grandmothers or mothers. But the people in community who have the most to lose, who are at the end of health inequity, that are experiencing or will experience the harm and suffering, need to have an active role in shaping the policies and practices and addressing and advancing the solutions to these problems. And we can get into lots of nitty-gritty detail about what that means, what it looks like on the ground in practice in our policy world. But I think at the crux of much of this is really a story of power, who has it and who doesn't, and how that dictates resources and their distribution, which ultimately track to who has access to a healthy life.
Can I just say, I love what you said about it going beyond the patient, because it really is like, if the patient is the mother, then obviously, we don't want her life to be diminished or to be, less productive or for her life to end. But if it is less productive, if it is diminished, if she does pass away at an early age, that impacts her family, her community, and it kind of, there's that ripple effect. And so I love that idea of even going beyond that patient voice and including the communities that are impacted by the health inequities. That's great.
And I thought that was the spirit of what you had said, I
You
was just
said it better, but
no, I was expanding and building, I think the spirit was there.
I don't have anything to add if you're waiting for me, Bryant. We can go on.
No worries, no worries. I'll just move on to the next question. So, building on that, what is one immediate action do you all think must be taken to begin addressing health disparities in communities?
Well, one of the points I wanted to make was that there's no one in the United States that can claim to be the healthiest person on the planet. Whether it's length of life or anything else, we have to all admit that we're affected because we live in this country that is so much less healthier than the others. So people need to understand that and then try to ask why. I mean, it's certainly not healthcare spending. It's not the process of providing healthcare. I worked as an emergency doctor for over 30 years, and I came to realize, I can treat illness and injury, but healthcare is not lack of healthcare is not the cause of illness and injury. So we have to ask a broader question and get the whole country to recognize that we don't want to be dead first. I think we deserve better.
well, and with that, I think there's this very provincial view of healthcare, right? It's treating the sick. But when you think of health, like what is health? How do you achieve health? I mean, you achieve it with having access to fruits and vegetables. And, you have these grocery deserts where you don't have access to a grocery store with good produce. And it is having safe communities to bike ride in and have parks and trails to walk in, and the infrastructure that allows people to walk to work or bike to work and not have, super highways that you have to drive everywhere. And so, I think, if we're going to change, healthcare in America, we have to think about what is health and not just think of it as whether someone is insured or not insured and if there's access to health. Of course, those are important. And, as a person that does work in the spaces that I do and that lives in the spaces that I do, I am deeply concerned about the trajectory we're on in terms of coverage and being able to take care of the sick. But I don't feel like we're at a point even where we can discuss, when we're cutting SNAP benefits from people and they're not able to eat. And I have my own clients that I work with where I am going to the food shelf now for them when I've never gone for them before because their benefits have been cut. People being able to eat food and healthy food impact their health.
Yeah, I appreciate. Oh, wait, I want to make sure Michelle gets a chance because I know you've gone last the last few times, and I know that's hard because then you're like, well, what do I got left to say?
It's my own fault for not unmuting quick enough. But
no, but it's not a race. I want you to go. I'll wait.
But I'd like you to go ahead if you're going to add on to what Sarah's saying. It makes more sense. So I'm happy to wait.
Okay. I was just going to say, I mean, I think an underlying theme thus far is around the concept that researchers are concepts that researchers often use, which a concept like social determinants of health or even structural determinants of health, right? Meaning we might think about healthcare and that makes us think about hospitals or clinics or insurance. and other kind of direct health care resources. But health, by the time you've gotten to the hospital, there are many, many other things much further upstream that have already shaped your health. And what can happen to affect your health outcomes at the hospital or in a doctor's office or in a clinic, that's important. But the vast majority of the harm has already been done, right? And it's been done in your workplace, it's been done in your home, it's been done in your neighborhood, it's been done in so many other domains that are outside of the immediate purview of healthcare, but within the larger purview of health. And we need to be thinking about both of those things at the same time. I'll give a concrete example, although I could give others. Even though in many ways I'm a traditional health policy researcher and I've spent a lot of my career studying Medicaid, which I can talk about all day and is really important, over the last several years, I've been doing some research that's focused on housing. And I've been thinking about housing as a kind of source of health harms. And there are so many ways that housing produces health harming conditions in people's lives, whether it's mold, whether it's the harm that you encounter when you face eviction, whether it's asbestos and lead, and so on and so forth. And so we know there's this relationship between housing and health. And if you've been exposed to lead or asbestos, if you've been breathing in mold, if you've been dealing with rodent and other infestations, by the time you get to a doctor, or even if you go to a doctor, there's really only so much they can do if those are the conditions that they're sending you home to. You might go home with a prescription that helps to deal with the symptoms that are emerging as a result of those underlying problems. But the prescription doesn't get you a home if you're being evicted, and it doesn't get you healthy housing conditions. And so it's really important that we think both about health care. People need insurance and they need to be able to go to the hospital and the doctor when there's something acute happening. And really, that's sick care, right? And we need that. We need to be able to get access to care when we're not well. But we also need the kind of structural and social elements of our life to be such that we're less likely to be unwell. We're less likely to need to go to the hospital or to go to the doctor because we can get healthy food. We can live in safe places. So the work I've been doing around housing has really looked at what does it look like for tenants to build power to address health harming conditions, whether that's through advancing local policy that regulates the conditions that they live in tenants so that they don't have to face those health harms, or whether that's by getting together with other tenants across regions, across states, or across the country to advance policy that makes it less likely that they'll be evicted, less likely that they'll end up unhoused, less likely that they'll be exposed to lead or asbestos or what have you. And so it's going upstream and building people's power so that they can address upstream issues, so that they don't even get to the point of having an acute illness that necessitates going to the hospital. If you have to go to the hospital, you want to be able to, right? So we can't throw out healthcare. But in an ideal world, fewer and fewer of us have to go to the hospital, need the prescription, and need to see the doctor because the things that are driving that are addressed.
And I mean, my answer kind of ties in, first of all, it's so hard what is the most important first step? I mean, there's so many things that it's just a hard question to answer. But going along with that, I mean, I think the low numbers of primary care providers and especially new primary care providers has to be addressed because if we could have more dedicated primary care physicians, PAs, nurse practitioners to provide that, medical home, that education, that support to then keep people out of the hospital, keep them from chronic illness. Your pediatricians are a great example of this, right? I mean, they're providing this anticipatory guidance to parents on what to expect and what to look out for. And if we need more of the primary care as just a small step in this large problem.
Awesome. Thank you all for that. My next question would be, in thinking of the patients and trying to honor the patient voice, how do we build those feedback loops that honors the patient voice and lead to real accountability in care delivery, whether it's at the doctor's office, um, at the emergency room, urgent care, or wherever?
Well, we've got to do more than just, the surveys that they do for the patients when they've been in the hospital. As a former hospital administrator, I know we have to do more than that. I think, patient advisory boards, caregivers, like as Sarah said before, involved from the beginning, not we're going to create a new program, and then once it's all created, then we're going to get your feedback when you're participating in it. No, let's start with one, what do the patients, the community, the caregivers need? Let's ask them, do they think we need this program? Let's get their input from the beginning. So very basic. Let's start with them, not end, and then get their feedback later.
Yeah, I always say that there's a difference between, on the one hand, voice, and on the other hand, power and influence, right? And I think that we have paid more attention in the last several years in particular to voice, and that's an important first step. And voice might be fill out the patient survey, picking a small number of Medicaid consumers, for example, or Medicaid beneficiaries to participate in a focus group. It might be picking a small number of people who suffer from a particular health condition to participate in a conversation or a focus group, or even be a part of an advisory board, right? Those are important ways of incorporating people's voices, and particularly people who have the relevant experience, right? And that I'm not going to downplay the significance of that. I think those things matter, but those have their limits. And we can invite people to the table, have them sit down, let them talk a little, and then we can go on ahead and do the same thing we would have done otherwise. And we can feel better about doing it because, hey, we invited some people to sit at the table with us. They didn't actually influence the decision, but we let them sit at the table. And I think we're at this point now where, I think we've been at a point where we didn't even think about who was at the table and whether those folks had relevant experiences or a range of backgrounds and such. I think we're at the point now where many people do think about who's at the table, and they want to make sure it's not just all one kind of person with one set of experience and so forth. And that's good. I think we now need to think about how decisions get made at the table and who truly has influence and power. And that requires a different approach, and an attentiveness to process and outcome, both, not just to kind of like tweaks around the margins that make us feel like there's some new voices that we allowed to enter into spaces that they weren't before.
If I can follow on to what Dr. Mitchner said, I spent many years as an emergency doctor blaming my patients for the issues that brought them into the emergency department. And then I learned that the longest lived country, Japan, had 3 times as many men smoking per capita than we did. And that just didn't compute. And so I had to change my mind on personal behaviors. And changing your mind is one of the best ways of discovering whether you still have one or not. So rather than blame my patients, I tried to understand what is the upstream factor that's driving these behaviors and driving the illness. The longest lived state, our healthiest state by any measure, is Hawaii. And Hawaii produced a report on health inequities in which they cited political context and governance as the most upstream factor affecting health. So that makes health political. And what is political? Again, is what Dr. Mitchner said. It's about power and who has it. And collectively, we, the people in this country, have a tremendous amount of power, but we don't recognize we have it. And so we cede it to a few people who then create the conditions that make us very sick. it makes them sick as well. As I said, healthiest person is never in the United States. So we need to recognize that power is what determines health outcomes and somehow collectively engage our power, which is greater than the power of the people in power.
I'll just add that I think you make a good point, Dr. Michener, about not just bringing the voices, but having those people actually have power in creating, being decision makers in the systems or programs that are created. And I think, one thing that makes that difficult in existing systems is that if you bring on, you know, a diverse group of people, there are, cultural beliefs and cultural expectations, cultural roles that, influence, people's beliefs about their own health, about what health should be. And so it's really hard for a rigid system like ours to take into account, um, a lot of differences, but I think of cultural differences. And I also think, in the one area that I worked in the HIV world, there's stigma, and there's probably stigma with other diseases too, that keeps people from not only participating, giving voice to what they want, but really being out there and being powerful, because there's this perception and perhaps reality that by showing their diagnosis, that then takes away, power. It stigmatizes them. So it's a very complicated weave of just intersectionality. Very complicated.
I agree. I think there are certainly barriers to building power and to seeing it exercised in our systems as they are, I think those barriers are all surmountable, and I've seen examples of that. But only when we actually acknowledge them, and only when we acknowledge that the key is power. And so then we can think intentionally about how to address the barriers to seeing it deployed and exercised by the people who have the most at stake and who are currently not like the ruling elite. But absolutely, I wouldn't want to romanticize or even fetishize like power as though it's just something that's going to be easy, right? I think it's extraordinarily difficult, but also quite possible.
You have to want it, or be willing to engage in it. But yes, I agree.
All right. Just backing up a little bit, what do you believe are some key factors that drive health disparities today?
I'll throw two things out there just because they're things that I study and they're at the top of my mind. So three things. And really, there's like, not because these are the three most important, because literally these are the three places I can claim expertise. And so I'll stick to that. So one, of course, is within our actual health systems, our policies. So I study Medicaid policy, and that is a set of policies and a program that affect tens of millions of Americans. And so the way that a program or a policy like that is structured, who has access, on what terms, what burdens they have to withstand in order to gain access, what benefits are covered, so forth. Those things really matter. So I'll say major health policies like Medicaid is, I think, really important. And then some of the social determinants that we've been talking about, the two that come to mind most prominently for me, like I said, because I'm studying them, and one is housing and the other is transportation. And so that's a range there, both in the healthcare proper and in terms of the kind of broader social determinants of health. I would name Medicaid, housing, and transportation as three spaces that are particularly important.
I'll go
I think I
on.
would add to that list two things that to me are the most important. One is the amount of economic inequality in a society. From 1975 to 2023, we've transferred $79 trillion, T with a trillion, trillion with a T, from the bottom 90% to the top 1%. And we're still transferring more and more and more. And it's the inequality that's really killing us. And there's a host of studies on this, and I've written a book, Inequality Kills Us All, and it's available for free from open source, and I'll put that on my website. So inequality is really the most upstream factor that affects our health. The second is the lack of attention to early life. There are only two countries in the world that don't give a working woman who's pregnant paid time off after she has her baby as a national policy. One is, of course, the United States, and the only other populous country is Papua New Guinea, half of a big island north of Australia. So we need to leave Papua New Guinea behind and be like all the other countries in the world and give a national policy of paid leave to mothers who have their babies to look after.
I like that. Yes, we've got to leave Papua New Guinea behind. They can be on their own in that category. I was just going to follow up with what Dr. Michener said and really just give examples from our undiagnosed community. So the people we work with patient navigation who are undiagnosed, I think medical records and access to their own personal medical records is a barrier. You know, we all hear about, oh, there's electronic medical records and you can just go in the portal. It's not that easy, and they don't always transfer. In fact, they frequently do not from one institution to another. Patients are told to just go in the portal to get everything, really not provided training, not provided support. It's a fallacy to think now that in the world of EMRs, everyone has access to their medical records. So that's really a barrier, especially for patients who are rare or undiagnosed and do need to travel for specialty care. So I'd say that one, and then the word travel, transportation, as Dr. Michener said, is a barrier. You know, I live in rural Texas, but I have to drive 8 hours to New Mexico to see my specialist because that's where the academic hospital is based on my geography, and I need to take off work. And you know, so are we supporting these transportation needs of people to get where they need to go? And could we be using telehealth more for some of these so that they don't need to travel, they don't need to take off work? So expanding telehealth would be huge for everyone, but especially our community. And then finally, the last big barrier in our undiagnosed community, so many of these diseases and conditions are genetic related, but there is such a shortage of geneticists and trained genetic counselors who can interpret the genetics. Just because it costs less than $1,000 now to get a whole genome sequenced, well, so what if you don't have the people who can interpret it and then deliver the information to the patients in a relative way to them? So for our community, I would say those are the big ones that we see as far as the key barriers.
And I'll just extend on what Michelle said on the undiagnosed. I mean, first of all, you have to recognize yourself as undiagnosed. And so, and until you do, because I think oftentimes, and it was my experience as a parent, is I didn't even recognize my daughter was undiagnosed until we were years and years in, because you just think, oh, we're getting sent to the next specialist, the expert of experts in this field, and we're going to get a diagnosis. And then you'd go to that specialist and they'd be like, well, I don't know what this is. You need to go to this person. And so, you know, you're like chasing specialists and you're just thinking, okay, well, the next, 3 months from now, 6 months from now, whenever I can get that appointment, that's, when we'll get the diagnosis. And so if you're undiagnosed, first of all, like, navigating the phone trees and the specialist referrals and getting access to care is one thing. And I think, being undiagnosed, the foundation really is the first nationwide organization really serving the undiagnosed as a population in itself. But when you don't recognize yourself, being in a group, then it's hard to access support. And so I think, whether you're undiagnosed or you have some other disease or there's some other barrier, it's finding the support that can help bridge you to where you need to be, whether that's food or housing or specialist care. It's having a patient navigator, it's having a social worker, it's having someone that can that speaks the language of the system to help you get to what it is that you need.
Thank you all for that. My next question will be for Dr. Bezruchka. As a clinician, how do you balance evidence-based care with the emotional and sensory needs of patients, especially those sort of navigating trauma or diagnostic uncertainty?
Well, take a not atypical person I would see in the emergency department. Somebody with a shopping cart, homeless, says he's been weak and dizzy for 6 months. I have to see him because of regulations, and I can spend $5,000 on investigations and tests to see whether he justifies being admitted to the hospital. Typically, I don't find a reason to admit him, and so I have to street him. If the nurses are cooperative, they might give him a meal, rarely a shower or something like that. What really is needed, if I was treating the whole person, I would find them a home. I would find them a community of friends because the social factors really matter tremendously. I would find them meaningful work and follow up. But that's not on the list of treatments in the formulary. So I have to send them back out on the street where all sorts of worse things are going to happen. And we have a huge unhoused population in this country. Back in the 1960s, I think I saw one unhoused person. Now they're impossible to avoid. So all this has resulted from political choices we have made as a society. Let's give everything to the rich. They'll invest it in offshore tax havens and we'll die younger. It just doesn't make any sense. So we have to recognize we're a very sick nation and treat the country as well as the individual that comes to the emergency department.
Yeah, thank you for that. My next question would be for Dr. Mishner. How do policies or reimbursement models unintentionally reinforce disparities? And if you could redesign one of those elements first, what would it be?
I always call this the silver bullet question, and I'm like, I never have the answer. But I think that I appreciate that you said first, which would imply a starting point and not like a kind of one single all powerful solution. And I really do appreciate that our conversation has spanned the range from really specific healthcare system level interventions like more geneticists or genetic counselors, better transportation, better navigation of administrative burden for different kinds of patients that face different challenges. And those are some more like, you know, system level micro interventions that are really important, that really matter for people's day to day experiences. And I appreciate that we've also uh, gotten to talk about the kind of high level structural and political determinants of those systems levels factors, right? Things like economic inequality and things like the role of the profit motive in our systems and so on and so forth. So, and I think that range is truly necessary. From a policy perspective, the issue that you mentioned specifically, the kind of reimbursement, my research has spent some time thinking, for example, about Medicaid reimbursement rates. And Medicaid gets reimbursed at significantly lower rates than certainly private health insurance and even Medicare, right? And that has implications, for example, for access. There are, many physicians and doctors' offices that limit the number of Medicaid patients they take. Because if they take too many Medicaid patients, they will be upside down in terms of the costs relative to the reimbursement. And in a system that is profit based, that is market based, where healthcare is a commodity, and in order to keep your physician's office or practice open, in order to keep your hospital open, frankly, even if it's a nonprofit or a public hospital, you need to make sure that revenue is outpacing expenses. And so, in that kind of a system, having low reimbursement rates for a population of patients who are disproportionately people of color, disproportionately low income, disproportionately have chronic illnesses. So you take those folks that are already suffering along a variety of dimensions, and then you say, when you treat them, you're going to get less on the dollar for every patient that you treat in this category of patients, right? It's a direct mechanism for linking inequality and access to healthcare, right? And those are the kinds of things we might think of Medicaid reimbursement rates or Medicare, frankly, it could work on reimbursement rates or what have you as wonky. But really, these are the mechanisms that reflect our values and reflect our investments. And what those mechanisms say is that profit is more important than people, particularly the kinds of people who we value least: people with chronic illnesses, people of color, people living in or near poverty, and so forth. And so, I think there are, I'll quickly say, two ways we can think about this. One is that we can tinker around the margins of that policy lever, and given where we are now and the current power dynamics, that's likely all that's possible. And that's increase the Medicaid reimbursement rate slightly, right? Just so that there's slightly better revenues in that system. People are more willing to accept Medicaid patients, and Medicaid patients have a bit more access, right? And again, in the system that has the power dynamics of our current system, where Medicaid beneficiaries, for example, are not a particularly powerful political constituency, you're lucky if you get any positive changes to reimbursement rates. But if you do, they're going to be at the margins, a little bit here, a little bit there. On the other end of things, if, as I've suggested and others have suggested in this panel, we continue to think about ways of fundamentally shifting power dynamics, such, for example, that Medicaid beneficiaries became a powerful political constituency, they could demand more than just slightly higher reimbursement rates, right? They could demand dramatically higher reimbursement rates, or they could demand a system where you didn't have varying reimbursement rates across populations of patients for reasons that are arbitrary, not related to deservingness, not related to need, but simply related to profits and revenue. And that system could be upended altogether. So if we look at even just one policy like that, Medicaid reimbursement rates, there's a spectrum of potential interventions, and which intervention that we take, the extent to which that intervention is either tweaking the system but generally maintaining the status quo, or upending the system and transforming it. Where you fall on that spectrum depends on who has power and how much. I think we need to be landing more on the far side of that system, on the transformation end of that spectrum. And we're not at the point where that's feasible yet. Because it's feasible, it doesn't mean it's not possible. It means that we have to think about what power shifts look like in the medium to long term. And in the short term, as we get there, some of these smaller tweaks can matter, can make a difference in people's daily lives. So every additional percentage that we increase Medicaid reimbursement rates, we should take it. It's better access. But we also need to be thinking about getting out of a framework where we're fighting for every additional percentage. And think about what bigger, deeper, transformative changes we might fight for.
If I can just add something to Dr. Mitchener, the big killer bill is cutting Medicaid immensely, and so many people are going to suffer the consequences of that. We spend $5 trillion on medical care in this country in 2023. That's a sixth of our total economy and half of what the whole world spends. And we get very little value for that. At the national level, we already spend more per person funded by the governments at those levels than any other country spends per capita. And they all have rich countries, they all have universal health care, and we do not. So we already can afford universal health care. We just need to use our collective power to make it happen.
Awesome. Thank you all for that. Which brings me into my next question, which is for Michelle and Sarah. What does it feel like to be asked to educate the system while still trying to survive it and help others survive it?
I guess I'll go. I thinking about that question, it, when I am fighting for care for my daughter, who is now considered partially diagnosed, I wear the hat of the parent. I don't actually wear the hat necessarily of the advocate or the social worker or the case manager. And, the even though I've experienced medical gaslighting and trauma as the parent of my daughter for over many years, and it can go many years without experiencing it, but when it happens, it happens. There's just this re-traumatization all over again, and I can't be the case manager, the social worker. I am the mother that feels traumatized. And so, but when I'm not being a mother, when I'm being the program development manager or the case manager or the social worker, I can use my experience, both my personal experience and lived experience in terms of just having seen and supported other families to advocate to change the system. And so I'm not often both things at once. If anything, I'm both things at once when I'm the advocate. I'm both the mom and the advocate when I'm the advocate. But when I'm the mom, I'm just the mom. And I'm just as vulnerable as the next mom in the next room. So I don't know, Michelle, what do you think?
I mean, I was just going to add that this is not unusual in our community, at least the educating of direct providers. I mean, we hear stories all the time from patients and caregivers of rare and ultra rare patients. I came to my doctor's appointment prepared with a printout of my gene and what the problem is for my doctor, or my doctor gave me the results of my genetic testing, but then didn't give me and tell me about your foundation that supports people with this disease. And so our community has learned that they have to educate their providers, that they frequently, when it comes to rare and ultra rare, are more experts on themselves, obviously, and their disease, frankly, than the clinician that they're seeing. And historically the power structure is that the clinician is the all-knowing. And, this is one of the things with patient navigation, really, that we're wanting to empower our participants and that, they know themselves and their bodies and changes and ups and downs more than any clinician ever could know. And, to really try and find a clinician that listens to them, that takes their input seriously. My son's neurologist, she always said, because he would say, my walking has gotten worse. And she would, if she was out of the country or something, she would email her colleagues and say, you need to admit him. Mitchell knows his body better than anyone else. And I don't care what your quantitative test says. If he says something is different, you need to listen to him.
Awesome. Thank you for that. All right. My next question is for Dr. Bezruchka and Sarah. What do you see being the biggest disconnect between patient needs and system design, especially those with multi-system complexities or rare conditions?
I'm not sure I can give a satisfactory answer there. The easiest thing you do in the emergency department is to give the person a referral to somebody else and a prescription for something. If you want to get rid of them, give them a prescription and a referral, and they'll leave. And that's not going to take care of their problem. Somebody earlier mentioned, I think it was in the chat, primary care. Countries that focus, well, as I've intimated, in the United States, it's very hard to make a case that medical care positively affects the health of people in this country. Some crazy notions. When doctors go on strike, morticians have less work to do. So that suggests that the work we're doing is not very effective. If you break medical care apart into primary care, that done by family doctors and nurse practitioners, physician's assistants, many studies show the positive impact on that. But most medical students in this country want to become a specialist because that gives them higher earning potential and they learn one or two skills to do well, and it makes our whole country suffer. So we really need to transform the entire medical care system so it serves people's needs rather than profit motives writ large.
And I would say that I think people want to be cared for, and being cared for means that they want more than just going and getting the prescription. They want the person, ideally, it doesn't happen very often, but ideally, they want, whether they're seeing their primary care provider or their neurologist, they want kind of whole person care. They want their doctor to understand not only their symptoms, to ask questions, to listen, to really listen to what is being said and maybe what's not being said. And our system isn't set up like that. Doctors don't have the time. They have a very short period of time where they need to evaluate and kind of decide next steps. They don't have time to consult with other physicians. And they don't, I mean, to really listen to people, to ask questions because you're listening takes time. It takes more than 12 minutes or 10 minutes or whatever you have. And so that's the disconnect. I think what people want and require for best care is more than what the system is set up to give. Even when doctors at their best want to deliver that care, they work in a system that doesn't allow for it.
Thank you both for those wonderful answers. My next question would be for Michelle and Sarah as well. What barriers do you see that patients face most often, and how do you help them get through them?
Well, I mentioned medical records and, just literacy when it comes to accessing their own medical records. That's a big one for our community. And so, the navigators, try and assist them and try and provide education. We'll do screen sharing. Okay, here's how you get on your, Epic or Cerner or whatever you have. Or, if you are in a rural community, here's how you can fax and get your medical records. Still using faxes in lots of places. And so, really just kind of trying to explain and, it sounds simple to some people, but understanding that, just, oh, I have all my medical records on a flash drive. That's not like normal, right? Like if you have your medical records on a flash drive, you obviously have some knowledge and understanding on how to, obtain and then store and send. So, just really trying to provide education and support on that. We talked a little bit about, access to specialists. That's something with the Undiagnosed Diseases Network Foundation. We really try and find specialists in areas that are taking new patients. We talk a lot about transitioning patients from pediatric to adult care. That's a whole nother webinar topic that we could have. So I mean, there's a lot of barriers. All these questions about what are the top ones. It's so hard because there's so many. But really just empowering, educating, supporting. That's how we see our main role as patient navigators.
I would, just thinking of the different populations that I work with, I work, like I said, with women and children living with HIV, primarily many immigrants, all poor. And then I think of the undiagnosed population that I work with. And we have not, in my opinion, accessed the people kind of on the lowest social determinants of health in undiagnosed, because I think the people who are undiagnosed, who don't speak English, who don't have transportation, who are poor, they have probably gone to the primary care doctor maybe many times, maybe the ER, and they don't really get further than that because their health literacy and their ability to kind of navigate systems and ask the right questions, know the right questions to ask, just isn't there. So I think, in the undiagnosed population that we're seeing, generally, we are trying to reach the populations that kind of face the most barriers. But I think, health literacy is huge, helping people understand what questions to ask next. Because I think if you don't know how to ask the questions, if you don't understand the information that's being shared with you, then you can't kind of advance and advocate for yourself. And I think on the other end of the spectrum, when I think of the immigrant women that I work with, it's access to, interpreter services. I currently work with a person who speaks Anuak, which is a very rare language. It's almost impossible to get an Anuak interpreter. Transportation is huge. Those in housing, like you said, Dr. Mishner, is, if someone is not housed, they can't get a ride to get to the doctor because there's no place for the taxi to pick them up, right? Or if their phone is off, which, a lot of times people I work with, their phone, they're not able to pay their phone bill. And so there's no way to access calling, to set up a ride. And so, or to make the appointment. And so, I think there's a broad spectrum of barriers. And yeah, I mean, I don't know what more to say about that than it just really, there's a wide span of barriers that families face.
Yeah, thank you so much, Sarah and Michelle. I couldn't agree more. There are a lot of barriers, and there are ones that we're trying to, fix and get rid of potentially with this new organization. And so that'll bring me to our next part. We're not done yet, but it brings us into the next part of Q&A. So if anyone has any questions, please feel free to use the chat, or if you want to unmute, go ahead and do so and ask your questions of our panelists.
Hi, everyone. I'm Michael Savelli. I have a question for the panelists that you brought up earlier when we were talking about infrastructure. When often the most affordable food for many families is the $5 meal or the dollar menu at the local fast food restaurant, it's a complication that seems like an impossibility to fix. Like, so how do we address the infrastructure of food deserts and cheap manufactured foods? Because it really does contribute to the health disparities that we have in this country, both rurally and inner city.
Yeah, I'll just say I think this one is tough. Um, but I do think it's an extension of the themes that have come up earlier around institutions that are oriented and built for profit in ways that are undermining of health. But in a context where we have a deep investment in free markets, I mean, it makes perfect sense actually to, as someone who, grew up in what I still affectionately call the hood, um, in the neighborhoods that like many folks try to avoid or try not to drive by. I know that the bodega on the corner or the McDonald's is where I can be. I remember as a teenager having like $1.50 in my pocket and trying to figure out where I was gonna get lunch during the summer when there wasn't school to anchor my meals during the day. And the dollar menu at McDonald's was where it was gonna happen. I was gonna get some French. I could get some French fries. This was years ago. Can't do this even anymore, but I could get some French fries and a soda with that $1.50 in my pocket. It's terrible for my health, especially on a regular and systemic basis. But McDonald's has every reason to put their businesses in those neighborhoods. That's where they're going to make a profit, and that profit is going to be at the expense of our health, right? And so I think, a few things. Um, One is to think about how and why we, how we might regulate some of what's offered in those places, to the point that I think Dr. Besruchka, and I'm sorry if I pronounced that wrong, made on many different occasions during this panel, and to great effect, I think. I remember being struck the first time that I went to a McDonald's abroad. And there's just things you cannot sell there. in, I mean, I've been to McDonald's in Moscow and London and all over the world, and it's actually quite different.
Yes.
So even something we might think of as like outside of our control, like what a corporation is deciding to sell, actually we can regulate those things, right? Um, and so I think that we can think about that from a regulatory perspective. I think we can think about it from a power perspective. How might we create demand and or demand funding for other kinds of resources and access in those communities so that the McDonald's isn't the only place that you can go? What are the streams for healthy foods that can be created in those communities? It will cost. It will cost. It will not serve the profit motive, but it will serve health. And I think that it is going to take the people who are on the ground in those communities and the people who want to make common cause with them, demanding a fundamental change in who decides what gets offered, such that it's not like McDonald's executives calculating where they're most likely to get a profit, but it's the people who are going to be eating the food available, deciding what sorts of resources ought to be available in their community. And some of those resources might be indigenous, right? Might be built by and for the community with resources from from the government or from local or state or other actors. Anyway, that's not an answer, but it's some scattered thoughts to a very good question.
Thank you.
So my perspective is that United States is one of the most highly stressed countries in the world. And stress is the 21st century tobacco. Not only the poor smoke, and that's to relieve stress. So what do the food manufacturers do? They give us comfort foods, foods high in fat and sugar. And those foods relieve stress, and you can demonstrate that very, very well. So unless we do something to relieve the huge amounts of stress this country faces, uh, the food situation is only going to get worse.
I'll just, just a brief story that kind of goes with that. I traveled to the Netherlands a couple of years ago. I was fortunate enough to be visiting my daughter who was studying abroad, and I was struck by the level of stress or lack of stress that I felt walking on the street. And it's really hard to describe unless you're there. But, you know, people let their children kind of walk ahead of them, like there wasn't fear that your kid was gonna, I mean, it's really simple things like there wasn't fear, you didn't sense fear that someone was scared that their kid was going to be hit by a car if they didn't hold their hand, because cars actually drove really pretty slowly. And bikes, so many, I mean, like ungodly amounts of bikes that that's what people they ride. 85-year-old people ride bikes, parents ride bikes, parents, kids in these little, baskets in front of, the bike, with their parents. And so the level of stress that I just felt walking on the street in the Netherlands was really palpable and different for sure. If anyone else has experienced that, it was something.
Yeah, good evening, panel. My name is Harold Brown. Excellent presentations. Really loved everything that I heard this evening. And Brian, thanks for pulling this together. I guess I've got two questions, one personal and then one for one for the rest of the panels. So I'm always interested in the why, how we arrived where we are. And I think I've heard a little bit of that from Dr. Mitchner and I believe Sarah. But for the other two panelists, if you can share, just what is it personally that drove you on this path to why you've arrived here, and even the other two who have already maybe shared that, feel free to chime in as well. So that's one. And then the next one is with this association or alliance that Brian is pulling together. Of course, this is a big topic, a deep topic. And what are, if you were advising this alliance, what are the next steps that this alliance really needs to take to make a meaningful move or a meaningful impact, although it may be small, considered how large, this problem or this issue is.
Perhaps I can speak to the how and why for me. Um, so I used to have I used to be a mathematician, and I decided I wanted to leave that useless pursuit and become a doctor. And because I thought that was sort of the most meaningful profession to help others. And along the way, I came to realize that that wasn't true. And I also realized that the health status of this country, our life expectancy was falling behind other countries, and I came to see that medical care was not the reason. So I went back to public health school, and I learned that politics and social factors mattered most. And then in 1995, I thought speaking to doctors would be the right thing to do, because my profession I thought was interested in health, and I came to realize they were kind of a useless audience because they're interested in treating illness and injury. So then I had to retool, and I went and I started teaching at various levels. And I've gone down, I've taken these ideas I presented as low as grade 5 and 6. And so, if what really needs to happen to change the health trajectory in this country, start teaching this in grade school. Young kids can understand that if you're not alive, you can't be healthy. And we die much younger than people in so many other countries. and give the reasons for it. And you have to retool the way you present these ideas. You can't do PowerPoint malpractice, but you can engage in storytelling, and it works pretty well. And at the university level, I teach courses in which the patient is the country. And so students get to get a sense of, well, rather than my telling them that we're not so healthy as I've done here, they have to do a population health web ramble. They search the web and they find out these things on their own. And then they have to devise a communication strategy to reach others. So it's, no politician, well, except Bernie Sanders recently and maybe AOC, have touched these ideas. Because I mean, yes, now RFK Jr. and his Make America Healthy Again, but you can't believe much of what he says. He says half of people in China are diabetic, and that's just nonsense. But anyway, we need to inform the public and we need to present concrete steps for action. And that's sort of what I have my students do. So that's sort of the how and the why.
I'd say for me, before I came to the Undiagnosed Diseases Network, and before my son got deep into the world of being undiagnosed and then ultra rare, I was a pediatric trauma nurse. So I worked in an urban pediatric emergency room and worked in one of the busiest emergency rooms in the country for pediatric gunshot wounds. And so that was really my first entry into the world of health disparities, to be completely honest. I lived pretty insulated suburban life, and as a pediatric ER nurse and then a pediatric nursing manager, I'll probably get emotional here, but seeing young Black children getting shot at such a higher rate than anything and knowing the statistics and seeing, that a lot of times these were frankly, caught in the crossfire because of, gun violence, because of social economic issues. So learning more about that and seeing the inequity there, and also just learning more about just the big picture behind it and witnessing just overt racism in kind of just the lack of government to do anything about it. And so that was really my first kind of entry into this world of disparity. And I was involved in some projects there, and and talk about a big issue that you really just want to curl up in bed sometimes because you don't think you actually are making any headway or making any difference. But I've taken what I learned there with pediatric gun violence to the world of undiagnosed and ultra rare, knowing that these systemic issues and social determinants of health really affect both communities and everyone, and just continuing that work with what I do now.
Thank you, Michelle. We are running close to time, unfortunately. Megan, if you could put your question in the chat, I'll be sure to forward it to our panelists to see if we can get that answered and email it back to you once that's available. Do you want to move into the last part to close us out? Ways you can stay connected with the Alliance. So you can follow us on social media. We're on Facebook, we're on Instagram, we're on LinkedIn. You can also join to be a member. Many different benefits to joining as a member. As I sort of mentioned in the beginning, the Alliance is open to everyone. You can join by scanning the QR code. You can email us at membership@nade.org. You can also visit nade.org/membership to learn a little bit more about the categories and associated benefits. And that concludes today's webinar. Thank you for joining us and helping to advance health equity.
Thank you.
And thank you to all our panelists today.
Thanks,
Thank you
everyone.
very much.
Have a good night.
Thank you all. Bye.
Bye.